Hi, this is Alicia Bright. We're going to be applying the nursing concept of cognition to the patient with delirium. We're going to use a case study for this. So we're going to talk about 84-year-old KP. Mr. KP has been in ICU for 3 days after unexpected major abdominal surgery. He had part of a descending colon removed for obstruction from diverticulosis. You'll remember diverticulosis are tiny outpouchings along the lining of the colon, and diverticulitis is a condition when these outpouchings become inflamed. With the inflammation, you can get scar tissue building up over chronic inflammation. You can get swelling and obstruction of the bowel. So Mr. KP had a bowel obstruction secondary to diverticulosis, and they performed colonectomy, removal of the colon. So he's now on post-op day 3, meaning surgery was 3 days ago. His vital signs are within normal limits. His abdominal incision is healing with no redness or drainage. You might document that as abdominal incision intact, no drainage or redness, staples intact, edges well approximated, meaning it's sealing up like we like it to. He's starting to tolerate an oral diet, probably sips and chips at this point, sips of water and chips of ice, and he's increasingly becoming confused and agitated. Whoops, okay, now we got a problem. Before surgery, he was sad, but he was alert and oriented. Post-operatively, he's trying to climb out of bed now, and he keeps claiming he has to get out of here, You can imagine his family is upset for not taking him home, and that his family members are very upset about his confusion. What type of cognitive impairment do you think he has? Well, obviously I'm lecturing about delirium, so the guy's delirious. And we're going to describe the difference between delirium and dementia. You had a discussion about dementia in your geriatrics class. And you know that is progressive deterioration of cognitive function, little or no disturbance of consciousness or perception. So people don't hallucinate. They still see normally. They hear normally. They perceive, they feel, they taste. These are normal, but their memory is failing. Their cognitive processes are failing chronically. They're not confused. They're forgetful. This is a term that refers to many different subtypes. Alzheimer's is a major subtype, but there are other kinds of dementias also. You can have a primary dementia or a secondary dementia, maybe dementia secondary to some kind of organic brain dysfunction, microclots or something. Dementia is generally seen as irreversible. Once you have it, the tendency is to continue with it and eventually get worse. Delirium, on the other hand, is a temporary situation. This is reversible with treatment. This is a disorder of altered cognition and disturbed consciousness. So people can actually hallucinate, they perceive things differently, they can have auditory or visual hallucinations, they can have their perception of the world disturbed. Their environmental awareness is dulled. They're not able to focus. Usually this comes on pretty quickly, over hours or days. It is a very frequent complication of hospitalization among the elderly, although it can happen to younger people too. And it's reversible with treatment. So the causes of delirium include, this is a little mnemonic, delirium, delirium. Dementia or dehydration, so these contribute to delirium. Any electrolyte disturbance, of course. Emotional stress will contribute to it. Lung, liver, heart, kidney, brain. This refers to any disease of those organs. Any kind of infection, of course, sepsis will do it. Being in the ICU will do it. We call it ICU-itis. That 24/7, 365 stimulation that you get from being in the intensive care unit with the beeps and the buzzes and the noises going off and the people talking, codes happening down the hall. It's always, there's a lot of stimulation going on in the ICU, and this can throw people off. Drugs, medications, side effects of medications can cause delirium. Anyone with an injury, they're in pain, or they're immobilized. If someone is stuck laying down in the bed, this throws off their perception of the world. It's unusual to spend that much time laying down, and it can throw people off. I've had people who feel like they're turning upside down when they're just laying there in the bed, and that was really the only delirium they had, but they felt as though their feet were way up over their head when I could tell that they were laying flat. It's just very strange perception happens. Metabolic disorders can cause this as well. So, quick quiz. An older patient is admitted to the hospital with a urinary infection and possible bacterial sepsis. The family is concerned because the patient is confused and not able to carry on a conversation. Which statement by the nurse is most appropriate? Depression is a common cause of confusion in older adults in the hospital. It's normal for an older person to have cognitive problems while in the hospital. The mental changes are most likely caused by the infection and most often reversible. Or, drug therapy with antipsychotic agents is indicated to slow the progression of dementia. Well, I hope you chose C, and this is why. Well, first of all, it's true. Mental changes are most likely caused by the infection, the sepsis. And as soon as we get this person on antibiotics, within 24 hours, she's going to feel a lot better. Let's look at those other answers. A, depression is not a common cause of confusion in older adults in the hospital. And this person was, if you look in the question, it doesn't say anything about this person being depressed. So that's kind of an irrelevant, garbagey answer. B, it's normal for an older person to have cognitive problems while in the hospital. Well, you know what we just discussed was that it's common for older people to have cognitive problems. That doesn't mean it's normal, so be careful about the language here. It may happen more often for older people, but it is always a sign of a problem, so don't accept it as normal. Accept it as a sign of a problem that often happens with older people. And finally, D, just don't go there. Drug therapy with antipsychotic agents is probably going to make them worse. We might use Haldol for someone who is very, very agitated if we need to calm them down, or even, maybe a little bit of a sedative, Xanax or Ativan or something, but most likely those medications might even make it worse. So we will avoid using any kind of medications for folks with delirium because the medications will probably contribute to making the problem worse. Okay, so you've got a patient with delirium. First of all, we try and prevent it. And I've got a list of how we manage delirium in a moment that will explain prevention strategies. But if we can't prevent it entirely, we want to recognize it early and we want to get them into treatment. So what do we do about that? Rest, sleep, nutrition, the basic stuff, regular elimination, pain control, comfort. This is basic good nursing care. Basic good nursing care will help people keep a grip on reality. An appropriate level of environmental stimulation. So I mentioned ICU-itis. That's what happens when you're constantly bombarded with noise and being in a strange environment. So actually music therapy will make it better. Just put on some quiet music for somebody, something soft and rhythmic, and that helps people organize their brains better. Having people on a predictable routine. Try and give them consistent caregivers. Use simple instructions. Don't overload them with information. Make good eye contact with people. And maybe have familiar people there, family members and familiar objects. Do make sure people have their hearing aids and their glasses and their dentures. Involve the patient in self-care and decision-making as much as possible. So if they're delirious, their judgment may be off, but that doesn't stop us from having the conversation with them about what's happening next. If we try to involve them in decision making, it helps them to track what's going on, and it helps them keep a little more grounded in reality and keeps a grip on what's really going on. Uh, Verbally orienting them to time and place and situation, and making sure that they've got a calendar, a clock, visual cues like pictures. We want to keep them safe. But we really want to avoid restraints if at all possible. Bed alarms are common now, and they can become a little bit controversial. They can be very confusing for people who are already overstimulated. Putting somebody close to the nurse's station where we can keep an eye on them easily is probably the best first thing to do. Hiring a sitter to sit in there with them and keep them safe is another commonly used strategy. We really don't want to use restraints. If we do need restraints, we need to contact the physician. We need to use the least restrictive form of restraint possible. So we won't tie anybody's hands if we can avoid it. And if they're ripping out the IV, maybe they're doing it with the right hand but not the left. Maybe we just put a little restraint on the right hand that keeps it from getting that far to the left to pull out the IV. But they could still scratch their nose if they needed to. You know, we really try and give them as much freedom as possible to support their autonomy. Anytime you have anybody who's this confused, I'm sure their caregivers are going to be very worn out. So we want to be sure and support caregivers, explain to them what's going on, give them reassurance that's appropriate, and make sure that they're taking care of themselves as well, because this can be thoroughly exhausting. Yeah, so the issues that we discussed in the beginning of this section on cognition, having to do with respecting someone's autonomy, and yet wanting to keep them safe, trying to do what's best for them. That comes into play a lot with this particular issue. And we want to do the best we can to keep our patients safe and help them recover and get a grip on reality again, while respecting their autonomy and from the attitude of beneficence.